Dr. Jagdish over here. Welcome to this live session for your PYQs test and discussion. We have some, PYQs, that are commonly asked, handpicked for you. But I know, see, theoretical discussions we've already done. There are a lot of extensive videos, and there is, rapid discussions. Everything is there on the app. But today I'm going to focus on how to think in terms of answering these questions from a exclusion or application standpoint. Okay, it may sound a little confusing, but see, many times we may not be able to remember everything because you're studying all 19 subjects, but sometimes there are certain clues that are there in the exam question and in the options that can give you a hint towards which is most likely the correct answer. Even if you don't know what the correct answer is from your knowledge, you can figure it out. And this figuring it out process is what I think all of you should understand how we do it in exams. Because as a student, I always used to get confused with MCQs. But when I started teaching and I started providing MCQs to examination systems, I understood how the creation of questions occur. And every examiner or every question creator struggles with good options, and somewhere there only they will give some option which you know that it does not fit. And many times I've seen the effort that is put in many of these NEET PG exams, INI CT exams on the options is so bad that sometimes they're like, yaar kuch bhi dal do, ye do teen mein hi confuse honge, and you can make out and easily eliminate. So let's go through that. All right, and I like you to be interactive so I can see whether you are there or am I just talking to myself, which is also fine. Parents as psychiatrist, wife psychiatrist, so treatment chal raha hai. But nice to be a little interactive. Okay, so basically today, not going so much into the theoretical aspect because they're very basic and the things that you've already learned. I will go into some amount of theory, but I'm going to basically tell you about the approach to the MCQ. Okay, so first rule of thumb: if it is a long question, always read from the back. Okay. Hi, Dr. G. Hello. Wow, Dr. G. Following drug is used in the management of which condition? Okay. So now, Mitomycin C. Okay. This is the drug that is being asked. And there are certain things that are put over here also. Subglottic stenosis, rhinocerebral mucormycosis, adenoidectomy, and tympanoplasty. What are you thinking? They've given a drug called Mitomycin C and they've told you which this drug is used in management of which condition. Now let's think about it, okay? Adenoidectomy, which is done in children, and tympanoplasties, where just repairing the eardrum, are some topics that are very deeply studied, and there is no role for any topical application drug generally in these surgeries. You do topical application only when you're going to see some raw surfaces that can come together to each other. Now here, okay, in tympanoplasty, you may think that, okay, if there is a hole in the tympanic membrane and they may close together, but that is what we want, right? We don't want to avoid that. We want the tympanic membrane, we want the eardrum, to close. So we don't want to avoid it, all right? So I don't think it can be used there. I don't think it can be used in adenoid surgeries. And mucormycosis, mucor has nothing to do. It's just got crusting and all of that. Yeah, you may think to avoid crusting, all of that, whether can mitomycin be used. Mitomycin C is an anti-metabolite. It's an anti-cancer drug, okay? It inhibits DNA. So it is it is something that prevents new growth. Generally, where do you expect new growth? Where do you expect granulation? In subglottic stenosis, there is a lot of granulation expected because this subglottic stenosis is most commonly caused when you put an endotracheal tube and that tube is remaining for more than 6 days or 7 days when the patient is extubated and then the patient goes home and then afterwards can suddenly develop stridor and then come back with subglottic stenosis, and this stenosis then becomes a regular affair. And to avoid that stenosis from occurring and avoid it from completely blocking the airway, we sometimes apply Mitomycin C to prevent granulation tissue, new growth, and prevent the fusion of that area and keep the airway patent. And that is why subglottic stenosis is one of the areas where mitomycin C is used. Mitomycin C is also very popularly used for glaucoma. Otherwise, it is a common anti-cancer drug for using in a lot of the pharyngeal cancers, breast cancers, thyroid cancers, and all of these cancers as an anti-cancer agent. Okay, but mitomycin C most popularly is for these kind of subglottic stenosis, can also be used for keloids, can also be used for recurrent respiratory papillomatosis. A lot of these conditions where you see granulations and you want to avoid granular tissue. Here in mucormycosis, especially, that you're seeing in the rhinocerebral area, these are all debris. These are necrosis. This is a fungal destruction of bone and soft tissue. Okay, there is in fact more space inside these nasal cavities, and there is invasion that is happening towards the inside. So an anti-cancer drug will not have much role in any of these other conditions. Okay, now here's a simple one. Following total thyroidectomy, patient is having difficulty in breathing and repeated attempts to extubate were unsuccessful. Okay, repeated attempts to extubate, not intubate. Extubate means you have removed the endotracheal tube and the patient has to be able to breathe on their own. The patient is not able to breathe on their own. What is the most probable cause is the question. Okay, and this examiner over here is very quickly giving a hint that there is something that has happened in this surgery where the patient is now not able to breathe on their own. As long as the tube is there from the machine, patient is able to breathe. When you extubate, patient is not able to breathe. So what is basically happening over here is, for some reason, the airway is getting blocked. Now, can it be a hematoma? Now, for a hematoma to occur, if the tube can be inserted and after you remove it and you can reinsert it, then it's unlikely a hematoma. And a hematoma in a total thyroidectomy is unlikely to occur close to the airway area. The hematoma may occur in the neck because generally it's an external surgery for thyroidectomy. So we are not expecting that. Unilateral recurrent laryngeal nerve versus bilateral. Superior laryngeal nerve palsy is anyway not going to cause any breathing problem. So here it is, of course, very clearly a bilateral recurrent laryngeal nerve injury. The only explanation of a bilateral recurrent laryngeal nerve injury was probably a malignant tissue. That is the reason why a total thyroidectomy was done, and maybe the surgeons could not salvage the recurrent laryngeal nerve on both sides. Had it been a unilateral recurrent laryngeal nerve, the patient will still be able to breathe because the other vocal cord would still be able to open and close. However, then they may have, occasional stridors and, that thing, but they will not have like this kind of an emergency where they cannot breathe at all, because the abductors, the recurrent laryngeal nerve supplies the abductor, cricothyroid. It's the only abductor. So it is, once the abductor is gone, it closes and there is nothing to do it. There's only one muscle, that is the abductor, which is the posterior cricoarytenoid. Okay, and the cricothyroid is a tensor. So the posterior cricoarytenoid, which moves the arytenoids backwards like this to open up the vocal cords, is now paralyzed because of the supply to the recurrent laryngeal nerve is hampered, and then that closes bilaterally, and patient is basically going to be having a good voice but having respiratory distress. Because the vocal cords are closed, the patient will be able to have good phonation. If the vocal cords are like this, where there's aspiration, patient will have a breathy voice. But here patient will have a good voice, but the patient will be in respiratory distress, so it is bilateral recurrent laryngeal nerve palsy. Okay. Long question, read from the last. Which of the following can also be seen during examination? Which means we have to go and read this. Sometimes they just ask something, which of the following is seen in a particular condition. Then you don't have to read the rest of the question. So they're saying female, nasal obstruction, discharge, loss of smell, foul smelling discharge, yellowish green crust. Merciful anosmia is a hint word, okay? So when you have merciful anosmia, they are basically a textbook definition of a particular condition called as atrophic rhinitis. Commonly seen in women, a lot of crusting, foul-smelling thing, and this merciful anosmia is basically because of loss of smell sensation, because of all of that destruction that has occurred, especially towards the roof of the nose near the cribriform plate. Patient is not able to perceive their own smell. and somebody very philosophically said that, look, their smell can be heard their stink can be felt by everyone, but they themselves cannot smell their bad, smell and discharge. So it is a merciful anosmia. So at least they have that peace that they don't have to deal with the bad smell. And that's how it comes. And one of the classical things of atrophic rhinitis out of these is a roomy nasal cavity, okay? Because of the atrophy that is occurring, an extremely roomy nasal cavity with merciful anosmia is a very, very characteristic, description. And we do Young's operation. Nowadays we do modified Young's operation. And Young was not a young guy, he was a very old guy, but is a British guy. And the people used to go for parties. Somebody used to have really bad smell from the nose. So they're like, instead of treating the disease, let us just close the nose, stitch it up, and you breathe from the mouth, or we'll make a very tiny hole after some time. And eventually, after some time, 3 months, 6 months, when they opened up the nose, there was some improvement. And that is because one of the organisms, Klebsiella ozane, which causes this, is not able to survive much if you cut down, the airway or the oxygen supply to it. That's why it's called ozane. It needs a lot of oxygen. It needs a lot of that, air to come in, and that's why it picks the nose where there's a lot of air. That's the entry part. That's where it gets a lot of oxygen and it thrives. By closing it, it reduces it significantly, and then there is a rebound improvement. Modified Young's, we don't make a complete closure. We leave about a few millimeters there. All right. Now, patient presents to the emergency room. Epistaxis means nose bleeding, no relief from pinching the nostrils. Okay, what is this pinching the nostrils is called? Pinching the nostrils is called Trotter's method. Wherever you see the word Trotter was somebody who was very much involved in the nose and nasopharynx area. There's a Trotter's triad also, which is there, a condition seen in nasopharyngeal carcinoma where the cancer enters the sinus of Morgagni, and that Trotter's triad. And Trotter is the same guy, works in the nasopharynx and the nose. So the moment Trotter hota hai, you have to think about the nose. Pinching the nose and bending forward is called Trotter's method. That did not work. Nasal packing was done. That also did not work. So what is the next appropriate? First line, Trotter's packing done, not working. So after this, we basically have to go for ligation. But what will you ligate? You ligate the maxillary internal carotid artery. Yeah, finish the bleeding source itself. Internal carotid artery, heat ligate kar do. Sphenopalatine artery or external carotid artery, right? So sphenopalatine artery, which is a branch of the maxillary artery, but we will ligate the sphenopalatine artery because this is also called as the artery of epistaxis. Okay, this is the artery of epistaxis. And this sphenopalatine artery, do you know where it is located? What is the landmark for sphenopalatine artery? How will you find it? Does anybody know where the location in the nose of the sphenopalatine artery is? Because it's an important artery and it's, contributes to bleeding, epistaxis, generally a favorite question amongst examiners in the vivas, or, especially this is an artery that we should know how to identify even in emergency medicine, even if you're not in ENT, because you should know the location of the sphenopalatine artery. That's the location of the bleeding. So, we have the superior meatus, middle meatus, and inferior meatus. Okay, these are the three spaces in the nose. All right, and they're all covered by the superior turbinate, middle turbinate, and inferior turbinate. So generally, if you go, right towards the end of the superior turbinate, okay, and this is called sphenopalatine foramen for a reason. It's near the sphenopalatine foramen, this area. So the sphenopalatine foramen is between the sphenoid and the palate, right? Right. So this is called as a sphenopalatine foramen, and this is, just anterior to the sphenopalatine foramen. The anterior lip of the sphenopalatine foramen is also a source of growth for the juvenile nasopharyngeal angiofibromas. Okay, that is where the JNA grows from, is from the anterior lip of the sphenopalatine foramen, and it is fed very well by the sphenopalatine artery, and the sphenopalatine artery is just in front of it, between the sphenoid and the palatine, in the sphenopalatine foramen area, right behind the superior meatus. बहुत सारा S है, superior meatus, sphenopalatine, foramen, sphenopalatine artery, all of that. Okay, so this is clear. Now here, this is a bit of a confusing one, so I'm going to let you answer it. Okay, post-tonsillectomy, tonsil has been done, patient bleeds. They don't tell how long after, but they say in the post-op room. So how long is the patient going to stay in the post-op room? There are blood clots which are seen. What will be your immediate management? Blood clots are seen in the tonsil in the post-op room. What are you going to do? You're going to shift back to the OT and remove the clots, or you're going to shift to the OT and just give IV antibiotics, pack and cauterize, ligate the vessel in the tonsillar fossa, or give anticoagulants repeatedly and repeat it, and then, or do blood transfusion and wait and watch, gargling and then wait for 24 hours. What do you think is the approach? Yeah? Anybody knows, Dr. G? Anybody out there? So what will we do? Is it good to have a clot right after your procedure? So Shesha Gopalan is seeing B. We will shift to OT, start IV antibiotics, pack and cauterize, ligate the blood vessels and the tonsillar fossa. So this is what Shesha Gopalan is seeing. Okay, anybody else? All right. First, the answer is a clot good right after? See, generally clots, happen after, when the healing process is occurring and the clot has to constrict. Okay. Here, the examiner is giving a very important hint that patient is bleeding from the operative site in the post-op room, and then there is a big clot. We do not want that clot to be there, because the clot is going to interfere in the, constriction of the tonsillar musculature and the vessels. Okay, the tonsil has to contract and stop all the bleeding, and then the slough forms and the healing occurs. Later on, if a small clot in the 2 days, 3 days later, if a clot forms, and that clot will slowly shrink with gargling. But this is immediate post-operative. There is some bleeding happening inside, and there is a big clot, and the clot is going to get bigger and bigger, and it is going to prevent the constriction of all the tonsillar musculature. So we will shift back into the operation theater, and we will remove the clot, be there until the muscles contract, hemostasis is achieved, patient is not bleeding anymore, shift them back into the post-op room and observe. Okay, but shifting to OT over here and giving IV antibiotics, packing, and then ligating the vessel in the tonsillar fossa, which is the peritonsillar vein, ligation is not warranted here at this stage. Okay, because generally a clot means a slow ooze. It is slow enough for clot to form. If it is a torrential bleeding and it is causing bleeding, aspiration and all of that, of course, yes, ligation can be looked at. But a clot means there is a slow ooze from somewhere because of lack of constriction, and we have to remove the clot. So all of you are right, Raj and Dr. S, both of you are right. So Shesha, this is going to be A and not B. Giving anticoagulants for bleeding, okay, and do blood transfusion and wait and watch. So this is, just for revenue generation. All right. Now, a patient with a history of chronic ear infection, a clue here, okay? Important clue, chronic ear infection. Here is an infective pathology, fever, headache, vomiting, space-occupying lesion, vomiting in the brain, irritability, confusion, again, going more towards, cranial. So Shesha is correct, coroner's clot, that's a name for it. His CT brain is showing in the image below. What is the possible diagnosis over here? Okay, here's when I tell, sometimes when you give an image, it's very hard for examiners to give you a good choice over here, because you can see the location over here. Yeah, so Shesha, you are right. Dr. S, you are right. Raj, you are right. You can see the location. It is in the temporal lobe, and there is only one option with temporal lobe over here. So there you don't really have to do any guesswork over here. You see a temporal lobe abscess. It is not meningitis. It is not cerebellar. There is no cerebellum seen over here. There is no subdural abscess. It's all fine. This is right in the middle. It is a temporal lobe abscess. I won't give good marks to the examiner for creating this question. It is very, very direct and straightforward. Yeah, it is a complication of ear infections. Temporal lobe abscesses can occur, and then this patient develops this as quite a dreadful condition. Needs to be treated very aggressively with strong IV antibiotics and close monitoring. Okay. Now, post-COVID, this COVID is gone, but the questions have not gone. Is a known diabetic develops unilateral facial pain and loosening of teeth. Which investigation would you do to confirm the diagnosis on this patient? Okay, so I leave this to you. This is a trick question. I want to see how many of you get tricked. Patient post-COVID, patient has recovered from COVID, patient is diabetic. So COVID plus diabetes, I already know what you are thinking. Develops a facial pain and loosening of teeth. Okay, even more closer. How will you confirm it? You do HbA1c, you do biopsy with histopathology, you do serum ferritin, or you do MRI. What do you think are you going to do for this? So Raj is saying biopsy. Okay, what about others? Anybody else? Let me wait for one more answer over here. What else do you think you will see? Will you do HbA1c, take a biopsy, do serum ferritin, or go for an MRI? So Shesha Gopalan is saying D. So somebody is saying this and somebody is saying this. Okay. Now guys, I will give you a very important trivia for MCQs. Whenever you see the word confirmation, see very nicely this examiner has slipped confirmation. Okay, confirmation, guys, to confirm something can only be done with histopathology if that is the option that is there. Whenever the word confirm comes and anything histopathological is there, then the answer will be biopsy with histopathological examination. So Dr. S is saying C, which is serum ferritin. Serum ferritin presence will never confirm the diagnosis, okay, which is mucormycosis. Okay, so serum ferritin may be elevated and it may be a supportive investigation. MRI can be a supportive investigation. HbA1c can tell, yeah, blood sugars were deranged. None of them can confirm. The only thing can confirm is the histopathology. You take the biopsy, you do the histopathology, and you look at mucor. And how does mucor look on histopathology? They are aseptate. Aseptate hyphae at 90-degree branching on KOH staining. Okay, so you do KOH staining and the biopsy, and you do the histopathology, and then you will see that there is this kind of, with maybe one or two septae, but not too many. If you look at aspergillus, aspergillus will have multiple septae, and then they will have a more less than 90-degree kind of branching. Black turbinate sign, Shesha Gopalan is saying. Yeah, so I think, Shesha, you've gone through a lot of these signs and names. So black turbinate is because of all the crusting and people give it some nice fancy names. Of course, yeah, black turbinate sign. So Raj, mucormycosis is correct because post-COVID diabetic patient, unilateral facial pain, loosening of teeth, you're expecting, a lot of, mucor infection to occur, and that can, cause a lot of bony destruction and can cause loosening of teeth. Okay, so biopsy with histopathological examination is what you would do over here. All right, now patient presents with the complaint of inability to close the eyes, drooling of saliva, and deviation of angle of the mouth. Which of the following nerves is likely to be affected? So we won't waste time over here. This is just the definition of a facial nerve palsy. Okay, inability to close the eyes, orbicularis oculis, drooling of the saliva with all the cervical branches to the buccal and marginal mandibular nerve and all of that. Deviation of the angle of mouth. Only nerve over here is facial nerve. Trigeminal nerve is a sensory nerve, and oculomotor nerve is it's a motor nerve for the muscles of the eyes, and glossopharyngeal nerve is again for taste sensation. So won't waste time over here. Very straightforward, facial nerve. Okay, adult man is at the restaurant, suddenly begins choking on his food. He is conscious. The following procedure: identify what this procedure is. You may have seen it in many movies. It's a, popular procedure. It is called as the Heimlich's or the Heimlich's maneuver. And this Heimlich's maneuver is basically to press right below the diaphragm and press it in with a thrust so that the diaphragmatic air pushes out anything in the foreign body. Okay, your chest thrust, back slap, and what is this blind insertion of the finger into the mouth and all are not really done. Heimlich's maneuver, very, very straightforward. Okay. If you're not able to do the Heimlich's maneuver, so there is sometimes they will put a twist to the question. There is, say, something is stuck, somebody has taken the food, and you do the Heimlich's maneuver, and the food is not going to come out. What will be the next step of action? What will you do? Let me say, if as an examiner I take this to that next level of question, what do you think can be done? If Heimlich's maneuver also does not work, you'll be like, "Arey, हमें इतना ही पढ़ाया था, हम जाते हैं, हमारा काम हो गया." No, you are there, you are doing the Heimlich's maneuver. You do all the back slap, thrust, whatever it is, doesn't work. What will you do? Which emergency procedure you can do to save this patient? Let's say you're in an aeroplane or you're in a restaurant, somewhere and this happens. What will you do about it? Anybody? Thoda sa lag hai, so when you answer, I take that much lag to respond to you. So bear with the lag. I think it's about 20-30 seconds as of now. CPR if unconscious. So Dr. Jain is saying you do a CPR. See, CPR is more for a cardiac, reason. So even if you're going to be able to do the CPR, what is the CPR doing? You're just going to be pumping it so that there is blood flow, right? But what is the point of the blood flow if there is no oxygen coming inside? What are you going to do? So Shesha, Dr. Jain, any of you are in a situation like this, needle cricoid. Yeah, so basically, Sudhanshu, we will do a thyroidotomy. Okay, it's a Greek and Latin word which means in the cricothyroid, you will do a cricothyroidotomy or cricothyroidectomy. It's actually called cricothyroidotomy. So basically, you will see this is the cricoid bone. And then you see the hyoid bone, all right? And then there is this membrane over here, which is the cricothyroid membrane, right? You can feel the cricothyroid membrane right below the Adam's apple and above the first ring. So cricoid is the first fully circular ring. You can feel that ring, and then you can feel the Adam's apple above, and you can feel a very small space over there. That is the cricothyroid membrane, and you can take any small needle. You can take a pen with the, a pen with the refill and poke and then take out the refill. A lot of things can be done. A straw can be placed, by putting it around a needle, all kinds of things. But once you do the cricothyroidotomy, the airway, patient starts breathing. And when patients start breathing, because the blockage is above, okay, and the most common site for blockage of food is in the cricopharynx. Cricopharynx is just the part before the esophagus starts, okay? So cricopharynx is the area where the food is lodged. So this is below it. So it will bypass that blockage and patient will start breathing. How long can the patient be like this? You hold that place, maybe put some sort of bandage and hold it in place, or have someone to hold it, and then up to 6 hours, maximum 6 hours, you will have to convert it into a proper tracheostomy. Okay, so this entire thing can be a question. So up to 6 hours we can keep Sudhanshu. So, sometimes patients have to travel and all of that. So you can keep the cricothyroidotomy. After that, a lot of secretions, a lot of edema starts blocking. But most importantly, you have the trachea, which is intact. And we have at least these first 3 rings of the trachea, which are very accessible to us. With a single incision, we can get to the trachea and put a tracheostomy tube and save the patient's life. So Heimlich's maneuver, you can try maybe 1 time, 2 time, 3 time. After that, don't give up. Make the patient lie down, arrange for a needle, and go into the cricothyroid area and allow the air to come in. Shift the patient to an emergency place where you can do an emergency thyroidectomy. Okay, so that is done. Now, a patient presents with a firm, tender, slow-growing mass below the ear shown in the image below. What could be the diagnosis over here? All right. So, looking at this location and in a child, this is clearly a Bezold's abscess because it's coming from the mastoid. Okay, Bezold's abscess is a complication of the mastoiditis. So that is where it is. A parotid abscess, parotid location is little bit more anterior. Bezold's is along the sternocleidomastoid. Sittelis is along the posterior belly of the digastric. Okay, lymphadenopathy and ostium of the mandible do not present like that. Deep cervical lymphadenopathy is a little bit more lower. So this is Bezold's abscess. All right. Now, a 5-year-old child presents with reduced hearing for 2 to 3 months. Otoscopy finding. What is this diagnosis? You can see it very clearly. There is very, very clear. What do you think this is? Let me just see. Because image-based questions are becoming very, very common. So what are the images that, what does this image tell you? Yeah? What is the diagnosis? It's a clear-cut image-based diagnosis. What are you seeing over here? What is the structure and what is behind it? Of course, it's the ear. It's a tympanic membrane that you can see. So Dr. Raj is saying A. Meningitis bullosa. Dr. Jain is also saying A. No, so you're getting a little bit confused because of the red color, okay? Santosh is also saying A. No, this is not the correct answer. Sudhanshu is also saying A. See, reduce hearing for 2 to 3 months, 5-year-old child, and you can see these bubbles. Can you see these bubbles? When you see these bubbles, there's basically secretion or like Dr. Jain is correct. It is a serous otitis media or otitis media with effusion or glue ear. Okay, in meningitis bullosa, you will actually see a bulbous swelling, red color bulbous, swelling. Here, what you're seeing, the reflection of the light and the poor contrast of the image, which is making you think it is like that. But you will not see these kind of bubbling over there. So this answer would be serous otitis media or secretory otitis media. Okay, now, patient comes to you with history of asthma and sinusitis. On looking in his medical records, you find out that patient has Samter's triad. The examiner ne de diya. Okay, now there is Samter's triad. What drug should be avoided in this patient? If you know what is Samter's triad, this answer is a no-brainer. But if you don't know Samter's triad, then you can also figure it out because patient has asthma and sinusitis. So you obviously, the role of this contremoxazole or chloramphenicol or comoxiclav is a little bit more, lesser. When there is sinusitis or inflammation, you can give aspirin, right? But in Samter's triad, patient has nasal polyposis, asthma, and intolerance to aspirin. Intolerance to aspirin. So aspirin should be avoided because they are intolerant to it. They have an inherent reaction to aspirin along with asthma and nasal polyposis, and this is called as Samter's triad. Very important because anti-inflammatories are very commonly given in such inflammatory sinusitis type conditions, and you should take this history to see if the patient has asthma and ever had any issue taking painkillers like aspirin in the past. Okay, now 70-year-old male. Now, this is a tricky question, okay? We're going to spend some time over here unless you answer it very, very correctly and clearly. 70-year-old patient, okay? Elderly patient. He's having decreased hearing in higher frequencies. So, they're saying it is high frequency hearing loss, okay? High frequency hearing loss. The basilar membrane was affected. What is a basilar membrane? If you take a cross section of the, aspirin should be avoided because it will increase leukotriene overproduction, Dr. Santosh is saying. Yeah, so whenever you have any sort of a reaction in your body, especially which is of the allergic nature or a response from your, immune system, you will have a lot of, leukogenic or leukotriene overproduction and your body is going to fight it as a reaction. All right, so that is correct, Dr. Santosh. Now here, when you look at the scala media, so this is scala vestibuli, scala tympani and scala media. Okay, this membrane is the basilar membrane. Okay, this is the basilar membrane. Here the question is, which of the following structures lie near the affected area? So Raj is saying, Dr. Raj is saying stria vascularis. Is it correct? Stria vascularis. Somebody is saying modiolus. Okay. And Ritik Tripathi is saying oval window. Wow. Ab helicotrema is the only one left. All right. Okay. Correct answer, guys, is the oval window, and I will explain to you what the examiner is trying to get to you over here. This examiner, oh, Anandita has said, chalo, helicotrema bhi dal dete hain. Very nice. Okay, but the correct answer is oval window, guys. Now, what is the examiner trying to ask you over here? Is saying somebody with high frequency hearing loss, sensorineural hearing loss, basically which part of the cochlea is affected and which is the structure closest to it. Okay. Now these things like stria vascularis is here. It is out over here. This is stria vascularis. This produces the endolymph. This is there throughout the cochlea. Stria vascularis is there throughout the cochlea. Modiolus is when in the cochlear turn, modiolus is this 2 3/4 turn. This whole turn is called as the modiolus. Okay. Now the question is whether the problem is in the apex or whether the problem is in the base, because in the base you have oval window. Okay. That is what they're trying to ask. High frequency hearing loss is affected at the basal turn of the cochlea. Low frequency hearing loss are affected in the apex of the cochlea. This simple information, very convoluted way, this examiner is trying to ask by telling there is a person, senior gentleman, high frequency hearing loss, and which is the structure that is closest to it, and that is the basal turn of the cochlea. Closest structure out of these to the basal turn of the cochlea is the oval window, and that is why they are asking. So that's what Dr. Jain is also putting over there. Okay, so that's a bit of a twisted question, but generally in PYQs I've seen same topics they take and they ask different kinds of question around it. Okay, identify the structure. This is very straightforward. Okay, so this is the incus. Okay, so we don't have to really get confused about it. All right, they usually ask what is the type of joint between the malleus, incus and stapes, and you should remember they are gliding synovial joints. Okay, so the gliding synovial joints. So the joint between the incus and the stapes. Okay, so incus and stapes. So if you look at this, this is the malleus. Okay, and then this will be the incus, and then this is the stapes. All right, this is a saddle type of joint, and this one is a ball and socket. And they are all gliding, all are synovial, type of joint. So this question also has been asked related to the anatomy. Okay. Now, 20-year-old male with recurrent bleeding. How many times you have come through this question? It is a recurrent question that causes internal bleeding, because this is a question they asked. 20-year-old male, unilateral bleeding and nasal obstructions in the past 1 year. Endoscopy is showing this image over here. CT scan shows mass extending from the posterior choana to the nasopharynx. So if this is the nose, okay, this is the palate. So the mass is extending from this area, from the posterior choana. So this area is the choana. From the choana to the nasopharynx, like this, the mass is coming out. The mass is not originating from the wall of the nasopharynx. So this is nasopharyngeal angiofibroma. Antroconal polyp, the mass will originate from the maxillary antrum and go back, nothing to do with the age. Concha bullish. Concha bullishella, it is concha bullosa. Concha bullosa is a pneumatized middle turbinate, and rhinoscleroma is a total different disease, causes woody nose. Okay, so here nasopharyngeal angiofibroma, extremely, it bleeds a lot. One question that is asked is, why do juvenile nasopharyngeal angiofibromas bleed so much? Why do they torrentially bleed? Does anyone know the answer to that? Why do JNAs bleed a lot, juvenile nasopharyngeal angiofibromas? Because they lack some of the elastic fibers and muscular contractility, and that's why it bleeds very profusely, and it has to be embolized and then removed. Okay. Okay, this is also a tricky question, okay? Which of the following procedures has been done in a patient who presents with features of early CA larynx? This is the clue. They could have just said CA larynx, okay? So why do they say early CA larynx? What are you seeing over here? Which of the following procedures? It's just depicted in the image below, not a very accurate image, but depicted in the image below. What are you able to see? Percutaneous tracheostomy, partial laryngectomy, cricothyroidotomy, or total laryngectomy? So I'll go a little bit into Greek and Latin and give you some language-based clue, okay? So Raj is saying D and Dr. Jain is saying B. Remember, when you make a hole, it is called a tomy, and when you remove something, it is called an ectomy. So there is CA larynx, but it is early stage CA larynx, and as you can see here in the midline, this is not exactly a midline thing. So this is most likely going to be a partial laryngectomy. The image in the total laryngectomy stoma will also look like this. But when you give an image like this and say early CA larynx, which could be like a glottic cancer or an early cancer, you can do partial laryngectomy, especially when both these options are there. There is an option of partial and then there is the word early over here, and plus it looks like it's a unilateral excision and this stoma is a tracheostomy stoma there to allow the place to heal. So that's why it is there, okay? If it was, yeah, so that's the only reason why partial laryngectomy would be the answer over here, because they mention early cancer larynx and partial laryngectomy is given in the option. If they just say CA larynx and you remove partial laryngectomy, this is a representative image and you can pass off as a total laryngectomy stoma also. However, you can notice that little bit of the midline, or maybe it's just a little teda image. I can see the neck over here, but is generally, I think it is a little bit more on a unilateral. So generally for partial laryngectomy, it is a sideways approach and one side of the larynx is removed, other side of the larynx is preserved. Okay. 30-year-old male came to the OPD with swelling of the face. On examination, there was proptosis, which is bulging of the eyes, history of trauma 15 years ago. This is an important clue here. It is not a recent trauma. If it is a recent trauma and you have proptosis, you are going to think about orbital hematoma, you're going to think about orbital, cellulitis, blowout, fractures, all of that. It's 15 years ago. That means when the patient was 15 years old, this problem happened. And this is the thing that you can see very, very clearly in the frontal area. You don't see any brain tissue there. It is very clearly a frontal mucocele. It is a very slow growing history of trauma, mucus, cyst kind of thing that grows in the frontal area, most common site. So no confusion over here. In meningioma, the brain also has to come inside the frontal area. We do not see that happening. The bony wall is intact. That's why we do the CT scan. Okay, so no confusion there. All right, here, 5-year-old child, difficulty in swallowing. On examination, bilateral swelling in the tonsillar fossa. Which of the following would be responsible for pain? Okay, so now which of the following can be responsible for pain in a patient with tonsillitis or bilateral enlargement of the tonsil? Auricular branch of vagus nerve is called as the Arnold's nerve. Okay, this is not involved in that. This causes coughing and dizziness when you're examining. Greater auricular nerve is a sensory nerve that just supplies this outer part of the ear. Mandibular nerve is not involved in these things. Tympanic branch of the glossopharyngeal nerve is the one that causes this. This is the same tympanic plexus that goes up to the ear also. So it causes referred otalgia as well. The Jacobson's nerve or the tympanic plexus that is formed and then it comes down and the tympanic branch of glossopharyngeal nerve supplies. All right, so the answer over here, guys, is D. So Dr. Santosh and Sudhanshu are correct. Dr. Jain is correct. So Dr. S and Anandita, the greater auricular nerve and the auricular branch of the vagus nerve do not, are not responsible for the pain over here. Now, which of the following is not an indication for instrument depicted? It's a trick question. I want to check if you are tricked or not tricked, okay? So which of the following is not an indication for this instrument? So you have to know what this instrument is and for which of these it is not done. So can you tell me for which of these it is not done? I think this is one of the second last question or something like that, maybe another few minutes left. after this. Or I think this is the last question, I'm not sure. But which of the following is not an indication for the instrument depicted below? So you're saying, Ritik is saying D, and Raj is also saying D. So I think looks like very straightforward. See, the way the examiner is tricking, this is a tracheostomy tube, okay? This is basically a portex. This is a portex tracheostomy tube with an inner cannula. Okay, and this is a cuffed tube. So you can see there is a cuff also there. So this tube is basically, you know, done in tracheostomy inside the thing. So here, tracheostomy level is from here and below. Okay, that is what it is connecting. The air from here is going down, and that is the passage. Nothing in the upper part is involved in tracheostomy. So there is no upper airway assessment that is happening. Yeah, you can do pulmonary toilet, you can give medications, you can do prolonged ventilation by connecting it to the ventilator, you can do you know, airway obstruction, this thing, but upper airway is you know, examined by other structures. Yeah, anything. You can do rhinoscopy, laryngoscopy, endoscopy, any of these things in the upper airway is that. For tracheostomy, it is only lower airway. That is the simple thing that the examiner is trying to do. From this 3D like image given below, identify the structure marked. Okay. All right. So guys, I must tell you that this structure is not very clearly marked. Okay. I think they mean this structure here. All right. But what is the structure? Can you make out what this is? Fossa of Rosenmüller, torus tuberous, eustachian tube, and tubal tonsil. Okay, let me orient you. This is the nasal septum, back part, and this is the choana. What you can see over here is the nasopharyngeal wall. This is the torus tuberous, and this is the eustachian tube opening. So this is the fossa of Rosenmüller, and fossa of Rosenmüller is an important area for the origin of nasopharyngeal carcinomas. Okay, nasopharyngeal carcinomas originate from the fossa of Rosenmüller, and what you're seeing over here is this. If they point at this turn, it is torus tuberous. If they point inside this, it is eustachian tube. If they point something like a mass over here, it could be adenoids or JNA. Okay, so this is how the nasopharynx looks. Not a very good image, but that is what is there in our database. Okay, this question also comes many times, so it is a repeat. Very common, you know, this thing. Here the clue is basically this image plus this 7-year-old child with history of fever and breathing difficulty. Fever and breathing difficulty in a child. So what is this? So Anandita Sahil is saying whether it is subglottic stenosis. Okay, what do you see in this X-ray over here? You see some sort of a narrowing that is happening over here. Dr. Santosh is saying laryngotracheal bronchitis. Is it this? All right. So Sudhanshu is also saying C. Dr. S is also saying C. This is very commonly asked. So I will show you what this X-ray is trying to say. Okay. You can see this is the airway. This is the airway, and it is narrowing like this. Okay. This is called as a steeple sign. Steeple sign. The steeple basically means in a church, you see this plus this narrowing is what looks like a steeple of a church. Okay, and that's why the name steeple sign has come, because it is like this. This can also look like a subglottic stenosis, but the subglottic stenosis will not have a history of fever and breathing difficulty. Okay, that is the clue. So this fever and breathing difficulty is seen in laryngotracheal bronchitis or croup. Laryngocroup, where you have barking, cough, and all of that. Thumb sign is seen in epiglottitis. Okay, when it is epiglottitis, you will see a thumb sign. So this is a steeple sign in laryngotracheal bronchitis or croup. Okay. Now, yeah, parainfluenza virus, you're right. So you know about all of that. Now, this is another question that has been asked many times repeatedly. It's important for you to know. 25-year-old female, OPD, difficulty hearing, Rene's negative for all of these, 256 and 512, but she's Rene's positive for 1024. What is the airborne gap? Do you know how to calculate this? So 256 hertz and 512 and 1024. what is the AB gap when it is rhinase positive? Okay, so here it is saying it is rhinase negative. It is saying it is negative for 256, negative for 512, but positive for 1024. What does this mean? Here there is, in these two frequencies, there is some conductive hearing loss, but at 1024 it is normal. Okay, so what does that mean? The airborne gap. For every jump of the frequency of the tuning fork, there is roughly a 15 decibel airborne gap. So at 256 you can assume around 15, at 512 you can assume around 30 decibel, and at 1024 you can assume around 45 decibels. Okay, and here since 512 30 decibel is in B, that would be the right option. Okay, so that's what Dr. Santosh, Dr. Jain, all of you are quite right. So this is B, 30 to 45 decibels, that would be the hearing. All right. So guys, the PDF of this lecture will be uploaded on this Telegram channel, which you can scan. Otherwise, I think the PYQs are fairly straightforward. And generally what I've seen in the pattern, even in this recent, INI CET, the same topics repeat. And ENT is very, very mathematical. It's very, very logical. Once you know some of the basic things, it's very easy to understand it. If you don't know it, that's when it gets complicated. And if you don't know from the concept and you don't know from the clinical application, it gets even more complicated. So if you understand it in a simple manner through the concepts, it should be fine. So all the best. Signing out, Dr. Jagdish Chaturvedi. Take care. Bye-bye.